Welcome everyone to today's webinar. I'm Morgan Hafner with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. This session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Shane Deering, Executive Vice President of Business Development at Real-Time Medical Systems, brings over 10 years of healthcare experience to Real-Time. Drawing upon his extensive background in government relations, healthcare policy, and business development, Shane strives to find innovative and value-driven strategies to bridge the gap between post-acute and acute care organizations. Phyllis Wojtusik, RN, Executive Vice President, Health System Solutions at Real-Time Medical Systems, has over 35 years of healthcare experience in acute care, ambulatory care, and post-acute care. Phyllis has led the development of a preferred provider SNF network for Penn Medicine Lancaster General Health. In this network, she developed and implemented strategies that reduce total cost of care and readmissions while improving quality measures and patient outcomes. At this time, I am pleased to turn the floor over to Shane to begin today's presentation.
Thank you, Morgan. We appreciate very much being here. We're excited to be here and even more excited to talk about the policy developments that are currently aligning post-acute and acute care models. And so today, my role with you is to first review our objectives and goals. And so I will look at things through the lens of my background, as Morgan mentioned, being heavy in public policy and lobbying. And we'll talk a little bit about the legislative goals and priorities that have brought us to this point with value-based care, and are presenting specific opportunities for post-acute care initiatives to both incentivize and deliver on savings opportunities in post-acute care specifically. And so with that said, I'd like to start off with a statistic from the UVA study that was released earlier this year and highlight why exactly our presentation today and the slide in front of you is very important to all of us on this call. And first and foremost, that statistic is 43% of inpatient surgeries today are currently performed on the population that's 65 and older. We know that this expects to grow to over 50% in the next 3 years. And so thinking of that and how more importantly, we get to the point where we're transitioning care and coordinating with our post-acute providers, we know that this is going to be an even heightened priority aside from the policy initiatives purely through the demographics in the country. And so here on our policy timeline, I would just like to highlight a couple items. The first is the IMPACT Act. So we know all about the Affordable Care Act and how visible it was in its passage and the programs, as you can see here, that have rooted out of it. But the IMPACT Act really furthered our coordination efforts, streamlining data and standardizing data sharing across post-acute, all post-acute lines of business, as well as the health systems. And even as recently as 2019, the IMPACT Act had an additional rule that required quality measures to be included upon discharge planning with those skilled nursing discharges. This presents an incredible opportunity for us to capitalize on the skilled nursing facilities, increasing emphasis on the care model and outcomes of their patients. Our next slide is about those specific items in the post-acute care space that are driving us towards these value-based purchasing incentives. Specifically, as you might be aware, we had a payment change on the post-acute side in 2020. PDPM, or the patient-driven payment model, has created an opportunity for us to focus in the post-acute setting on clinical reimbursement rather than therapy reimbursement. And that's important for us as we move from a fee-for-service model to value-based purchasing in the skilled side, is that they're now going to be incentivized to not only care and provide the outcomes that will benefit hospitals upstream, but also financially reward them in the same manner that we see on the acute care side. In addition, we have capitated rates on Medicare Advantage, and we find ourselves, oh, sorry about that. Oh, we've got a few slides ahead here. Sorry about that. All right. We have a few other items here that I'd just like to point out as well before we get into how Phyllis was so successful with LGH. So because we're also seeing a squeeze on rates through Medicare Advantage and really more and more Medicare Advantage rolling out across the skilled setting, this is allowing them to focus on those capitated rates that allow them to get people out of the skilled nursing facility and manage length of stay. In addition, Medicaid rates are falling, and with the MFAR rule of 2020, we now have further concerns about those Medicaid rates. And now with shared savings being top of mind with skilled nursing facilities, they're more likely to be willing to adapt to the standards of care and the models of care that you on this call could present to them in partnership. And then the last piece would be the bundled payment initiatives. While in advanced, these SNF facilities are very active in coordinating and interested in coordinating with health systems across the country. The last point I'd like to mention before handing it off to Phyllis is that we do have a specific care model in post-acute care that's really exciting. So the Institutional Special Needs Plan, or ISNP plan, is a long-term care Medicare Advantage plan that is based on ICD-10 and PDPM. So again, those aligning financial incentives alongside those clinical models is providing for facilities the capital through premiums to invest in nurse practitioners, invest in SNFists, and participate more actively with the coordination of care and transitioning from the acute care to SNF market. And so if we consider all these things in a historical perspective, we have the SNF value-based purchasing penalty that was levied on 73% of SNFs last year. That's exciting news because we now have their awareness and attention and focus on ensuring the reduction in readmissions. And so with that being the case, we believe that driving towards value-based partnerships are going to be the key motivation to driving savings in this space. And so with that said, I'll hand it over to Phyllis to talk about exactly how we're able to do that and suggest ways that you can too.
Thank you, Shane. So I'm going to be talking about why have a partnership, what does a post-acute partnership mean and look like, and how can you be successful at it. And I know many hospital systems out there have preferred provider networks or post-acute networks, and some of them are just in name only. Some people have put out RFPs and said, here, you need to meet these quality metrics, but they don't really engage at the patient level and the care level, and I think that needs to change. So a little bit about kind of what is a post-acute network and why do you need to align, not only from a value-based perspective, but from a care perspective. So I found this quote in an ACO magazine, and I thought it really demonstrated what you need to be able to do with your post-acute network. So focusing on care transitions is a big piece of that. And not only the transition from the hospital to the SNF, but from the SNF to the next level of care, whether that's home with home care, home, or to another SNF level provider. Making sure that your staff are following that patient all the way through those care transitions and settings. And then information is key. We can't manage people without information. And so being able to tap what's in the EHRs of either the post-acute provider or skilled nursing facility and understand at that detail level what's happening with the patient, I think is a really important thing. Remember, SNFs have had a different focus for a long time, and it's only recently that their payment model has changed and focused more on conditions. So while it's been a functional reimbursement system for them, as Shane mentioned, it's much more condition-based now. Hospitals have that knowledge base to be able to share with those SNFs why it's important to focus on condition care and not just functional care. So with that being said, what does a successful post-acute network relationship look like? So again, when this all started maybe 5 to 7 years ago and we really started putting networks together, many hospitals sent out RFPs, looked at quality data. Of course, we looked at readmissions and length of stay, but we didn't go beyond that in terms of how do they actually care for patients. And so it was much more of a dictatorship. You will do this, you will do that. that really doesn't bode well for a successful relationship. So when you're building your network, or if you're resetting your network, one of the most important things is starting with a shared vision of what that partnership is there to drive. And so I think most people can relate to what's the right thing to do for the patient, because that's what drives care, costs, and outcomes. And so if you set the right tone with your vision up front, then the health system, the post-acute partners, whether they're SNF or home-based, really have to kind of follow along because it is the right thing to do for the patient. I think as you start to go, you can't unilaterally build metrics. You need to understand other levels of care and what their metrics are, and include those metrics in your overall outcome. And focus on process driving care, not just the outcome. And then I think one of the most important things is having honest communication. If you can't be honest with your partner, if they can't tell you that, hey, you're messing up on the hospital side, you're sending us patients that, have fevers or low blood pressures when they arrive at the facility, then you need to be able to get to that honest dialogue, because that's when you're going to figure out what process improvements you can make when you understand what's driving that. So I think honest communication both ways. And the little quote that I have there, if you're really actively working together, you certainly achieve more than if you're kind of butting heads and opposing them about what's happening. And I know that many SNFs feel like they're being watched, if you will, or they are being monitored closely, and it's kind of that big brother type of relationship. You want to get beyond that, because that's when you'll be most successful. So how do you do that, and why is it important to monitor care through all the settings that you're talking about? So again, this goes back to vision, and as you begin to determine what outcomes you're going to measure across your network and across the continuum, you cannot directly give that care yourself. You have to lead and inspire those teams on your post-acute network to carry out your vision. So leading with a passion, I think, is very important. And again, setting that vision about the right thing to do for the patient at the right time, even if you understand then that your approach needs to change, that's a really important piece when you're building up a successful network. Certainly you need to abide by national clinical standards of care. So you want to drive towards standards. We all know that standards improve outcomes. And so on the SNF side, there really haven't been those clinical standards. There are standards out there for SNFs and post-acute, but they haven't been disease-oriented or disease-focused. And so it's very important that you include national standards that they can drive to as well, but you also need to include their national standards. So standards like Interact, AMDA has standards out there clinically as well as process-wise. Include those standards when you're building clinical plans or pathways, or you're deploying what your strategies are across those post-acute partners. And then the third thing I would say related to this is education. Education helps you drive towards a common goal and a common vision. So while you expect your partners to deliver a standard of care, remember the frontline people caring for the patient in the SNF are not RNs. They may be LPNs, they may be nurses' aides. You really have to be able to deploy education across that network, so you are clear to those providers what is happening and what they need to do and what your expectations are. And so I think that is a really important piece as you expect, a certain standard or level of care from your post-acute networks. So a couple other things around successful relationships. If you don't check in on your relationship, you don't really know how it's going. So having regular meetings and understanding what's happening on both sides of the aisle, building metrics-driven discussions. So having routine readmission meetings, looking at why those readmissions occurred. When did they occur? Are they in the first 3 days? If that happens, that is usually a transition of care error, and it could be related to how you are discharging the patient. Looking at length of stay, understanding all of those metrics that you really care about and bringing that to the forefront every time you have a conversation. And then if you're working in a network, we have been very quick to hide data and not tell each facility how they're doing in front of the others. We really feel that unblinding the data is really important. That provides a level of competition between your post-acute providers, and it helps drive them towards success. And then the last thing on this slide really is about listening. Listening to your post-acute providers, understanding the challenges that they face and how they maybe need some assistance from you, or you may need to change expectations based on what they're able to provide. If you don't listen, they will become frustrated and disengage, and then you're not driving towards the quality and financial outcomes that you really want. I think that's a very important piece of it. So how do you manage this post-acute network that you're building? I think there are really 4 key areas. First of all, focusing on transitions of care, those clinical standards that we talked about, identifying moments where you can intercede and prevent poor outcomes, which is interventional moments and directing care, and then building a data-driven referral process. So rewarding people, facilities, who are doing well with metrics that you care about by increasing their referrals. I want to talk a little bit about each one of those pieces. So let's talk about transitions of care first. So what is a transition of care? CMS defines it as the movement of a patient from one setting of care to another. They don't say it has to be from a higher to a lower setting of care. It can be either way. Care settings include, obviously, hospitals, ambulatory primary care practices, that's a care setting that's in the community, specialty practices, long-term care facilities, home health, rehab facilities, all of those are settings of care, if you will. So why is it important to transition the patient from one level of care to another? And what do you have to do to be successful at that? We know that when a patient is discharged from the hospital, the highest likelihood of them being readmitted from a skilled facility, but even from home, is in those first 3 days. And the biggest reason for that is medication errors. The patient either doesn't understand what they're supposed to take, they don't know exactly what they're doing. Yes, we hand them a list. Yes, we tell them. But when you're in a hospital and sick, it is really hard to absorb that type of and level of information. We even have those issues when we transition a patient from a hospital to a SNF. So focusing on transitions of care really can cut down your readmission rate very quickly. You need to get complete information. It needs to be accurate and timely. One of the things that we did in the network that I ran is we sent information ahead of time so that the SNF could prepare for what they were going to receive. They knew what meds the patient would have. If they had to get something that was outside of their pharmacy, they could go ahead and get that at that time so that when the patient arrived, they were actually ready to receive them. So oftentimes, healthcare providers, wherever we practice, are guilty of sending everything in the chart. Okay, you want all the information? Here it is. Here's all the things that you could possibly look at. Well, that could be 150 to 300 pages. No one who's caring for a patient has the time to look through that information and understand exactly how to care for a patient. So while it needs to be complete and accurate and timely, you cannot expect a receiving caregiver to go through that many pages to find out what they need. We recommend that you put a quick guide, a transition of care sheet together so that you can easily get the information you need quickly to be able to send the patient, receive the patient, and care for them. And then those types of things should be customized for your post-acute network. So what I'm saying here is not only from a hospital perspective do you need to say, here's the information you need to care for this patient, you need to listen to your partners and say, what information do you need to be able to care for that patient? So I think that's a really great foundation to start at, and you would be surprised at some of the answers that they have, things that you might think aren't important, but are very important to them in that care setting. Let's talk a little bit about clinical standards. So we did talk and say that they should be based on national guidelines. You want to drive them to care for the patient the way you would care for them in the hospital. Doesn't mean they would do all of the same things that you would do in the hospital, but you need to make sure that on a daily basis, the key items that are needed to care for that patient are happening. And so when you're sharing clinical standards, there's several ways to do that. You can have protocols, you can have clinical plans or pathways. You need to make sure that those things are embedded into the daily care process. And so I'll give you an example of something that in my network I thought was going to be easy to achieve, but really wasn't. On CHF patients, we all know that a daily weight is a really important piece of information. When I asked our network to do that from a post-acute SNF provider, they balked because they're like, you know what, I only have one nurse aide on from 4 a.m. on. They can't do 15 daily weights, so we're not going to do that. And then when we pushed back and made them understand that, you know what, this is the gold standard in how you're going to prevent a CHF readmission, they really did understand. It wasn't just because we wanted another data point. It's because it really mattered in the care process for the patient. And so adjusting your expectations for care settings are really important, but sticking with key clinical findings that you know drive care and readmissions for that patient is also important. One of the other pieces that we felt was good or that we felt was really important was standardizing patient education. So when the patient's in the hospital, they get, they go to CHF classes, or they have an NP talk to them, or they have an educator come and talk to them. In the SNF, they may have a completely different version of what is CHF, and they may not drive home the same points that you feel is important for the patient to manage their own care once they are discharged. So standardizing that education, agreeing to what happens, and keeping it from the hospital all the way through their SNF stay really drives patient engagement and understanding, which leads to increased compliance. If the patient's told too many different things, then they just get confused. They don't know what to do. This way, you're focusing on 3 or 4 or 5 key factors, and you're able to drive that education and get better compliance from the patient perspective. One of the key things is having a line of sight into what's happening with the patient at the skilled nursing facility. So finding any clinical indicators. So if it's CHF, finding the weight is going up over the last 3 days. Noticing that they have edema and a little bit of shortness of breath, or their pulse ox seems to be dropping. Those type of clinical indicators are really important in preventing a patient from coming back to the hospital. Facilities are very capable of treating in place. They're able to give IV diuretics. They're able to monitor the weight and vital signs. They can do all those things. They may not just understand that where this patient is trending. So having line of sight into that clinical situation via a case manager and the real-time product, which I'll talk a little bit about later, I think really gives an oversight that is needed and that improves care outcomes. Then once you identify what those clinical indicators are, those interventional moments, communicating those with the appropriate staff, both at the facility and at the hospital, whether it's a case manager, a CHF clinic, whoever that might be, and then allowing those staff members to empower change in the care process and get either orders or use standardized sets of orders to be able to act on that clinical indicator and prevent the patient from getting readmitted. So I think putting some power back into the clinical staff, both at the facility and at the hospital, helping them engage back to the provider and getting the information to that provider and identifying what change in care plan needs to be had is a really important piece of how to drive care process. So I want to talk a little bit about data-driven referral process. So in hospitals, typically the way you would transfer or get agreement from the patient and their family to go to a SNF is you would hand them a list of facilities, tell them that they needed additional care, and say, here, pick one of these facilities. And invariably, the patient and their family, they pick the one closest to their home because that's where the wife can get back and forth or the daughter can come and see the patient. And so there's no other criteria other than geography being used to pick the next care provider. We all know that in this era of value-based care, that working with the right post-acute providers is very important. And looking at outcomes and sharing those outcomes is also very important. And that's where the Impact Act comes in. So we're required as a hospital to share more than geography. Quality data, readmission rates. I know that many people use the CMS 5-star rating, and I think that's a good start, but I don't think it's enough. So allowing and understanding that patients do have choice, but giving them the right data to make a good choice is important. Endorsing or giving a seal of approval to those facilities that you work with that are your preferred partners, I think is also important. You know, maybe there's 3 SNFs that are close to that patient's house, and one of them is your partner, and guess what? They have great low readmission rates, they have a lower length of stay, and their outcomes are better. Well, don't you want that patient to be able to go to that facility? That's very important because it not only drives that patient's outcomes, it drives your outcomes. So identifying who your partners are, giving them that good housekeeping seal of approval, and giving more data than just geography is very important. So the other piece to that is managing your network from a results-oriented process. So I would not be a nurse if I didn't bring up Maslow's hierarchy, and we've changed this just a little bit to reflect on how you manage your network and your program. So we started talking about showing what the vision is, which we all agreed was important, and then setting up clear goals and objectives, your key performance improvement indicators, and then measuring. So the groundwork of change is measuring what your outcomes are. And not just measuring and keeping them to yourself, you need to constantly put them in front of your network. People change with data. And if you're not providing data that is timely and accurate, then it's hard to get people to change and design new care processes or do something different than their current process has been. So one of the things we felt was important in our network is we started every meeting with what the data was showing us, where we were at with our goals, what our readmission rates were, and how we had been improving. Because you don't do that alone, you do that with your network. Constantly measuring and then highlighting those partners in some way who are really doing well. One of the things we did is we had an annual retreat for our post-acute partners, And we were able to give awards, if you will, to certain facilities who had achieved the greatest readmission rate reduction. Partners who improved process or had come up with an idea that was shared amongst the network. And as we did that, people really strive to improve and look at process and do better. And people vied for those types of results, not only because they wanted to do it for the patient, but because they wanted to be highlighted in the network as a really good partner. And it was very important from that perspective to them. So keeping that vision, goals in front of you, and then rewarding for outcomes really drives engagement at the facility level. Now I just want to review what our case study was in the network that I helped to run and how we were able to use real time, which gives line of sight clinically into the SNF, what we were able to do. So the background is this was a 4-hospital system, had over 700 beds and 35,000 discharges, so a significant number of discharges. About 4,000 of those discharges went to SNFs. So what were our challenges? So we found that in our network, through our ACO, our costs on post-acute care were double the national average, and it all related to length of stay. And it was a strategy that the SNFs used to be able to make a margin and sustain that margin. And so they drove up length of stay, and they had never been incentivized not to. So as we started our ACO and we saw that issue, we knew that we had to address that in some way and get people to understand that the relationship we had with them goes beyond just 3 more days of a skilled patient staying in that bed, and that we were willing to switch volume out of our hospital to partners who performed at a higher level. So as we started to do that, we picked a preferred provider network. We used multiple criteria. We wanted to make sure we covered our market. We looked for 5-star facilities. We also looked for facilities who we either had physicians attending at that facility, or we had partnerships with physicians who were there. And then we started to measure readmission rates, length of stay, and really focus on total cost of care, because that's the ACO model. So the majority of our ACO was a Medicare shared savings plan. We built a clinically integrated network. We worked with these facilities to be part of that network, and we determined a payout structure that would help benefit that network. So how did we do it? We built this network. We looked at those metrics: length of stay, quality of care, readmission rates, and patient satisfaction with that. We focused around transition of care. So were we discharging all of our patients on Friday night after 8 p.m. and they would come back by Monday morning at 6 a.m.? We looked at improving how we handed off communication, calling the facility before the patient was ever discharged to make sure that they were ready and could accept the patient, and that they had all the equipment and medications and things that they need. Once we started working through those issues, we really deployed standards of care using clinical pathways that the network could easily look at. And we monitored those patients separately. We had 2 case managers who monitored the high-risk patients, but they also managed our bundle patients. So CHF was a big one for us. We were able to drop length of stay in the CHF patient by putting out that clinical standard of care. And then utilizing real time to be able to see what those interventional moments were about. When did we need to intervene in the care of that patient and assist our partner, the post-acute SNF, into doing something different with that patient so that we could keep them in the facility, linking them back to a specialist, getting them an appointment, all kinds of things that really helped improve and impact that patient's care. And then we also looked at when the patient was going to be discharged, getting the patient back into our system. So having a patient appointment back to their primary care doctor before the patient ever left the facility, making sure that there was a way for meds to be delivered if the patient could not get their prescriptions filled. Again, those are that care transition pieces, and we not only worried about them on the front end, we worried about them on the back end. So those were some of the things we did within our network. And now I want to show you what some of the results were by doing that. We achieved a 52% readmission reduction rate. We started about 18% readmission rate, which at the time we started doing that, the national rate was 25 to 26. So we already felt like we were doing well. But when we really focused on that, we were able to drive our readmission rate down to about 8.5%. And it was really significant, and that made a huge impact into those patients who were not readmitted. We also managed a 43% decrease in length of stay, and that was really by standardizing care, identifying patients who could go to the next level of care, and setting them up for successful transition back to their primary care network and back into our system. And then when we looked at that, that was a $4 million savings in one performance year related back to our ACO. And that was because of decreasing length of stay and stopping those readmissions. So we were very successful at using a preferred provider network to improve outcomes, decrease costs, and improve patient satisfaction, which isn't on here, but we did see patient satisfaction go up dramatically, particularly in those cases where we had clinical plans that addressed the care of them in the facility. So very successful network. And now I'm going to turn it back over to our moderator to be able to go through some of those questions that might be out there. Thank you.
Thank you, Shane and Phyllis, for that fantastic presentation. We'll now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for today. And there's a lot of great engagement from everyone online today. One particular question that arose is around bundled case managers, and an audience member was curious if you could expand a bit on what a bundled case manager does.
Certainly. So a bundled case manager is someone who follows a particular bundle. I'll use CHF as an example. From the time the patient's admitted and identified in your hospital through that 90-day period that CMS requires you to follow them. So they would keep touch with the patient, whether they're in the hospital, whether they're discharged to a SNF, whether they're home with home care or home directly out of the hospital. So you're looking to do a few things. Make sure the patient understands what their condition is, what they need to do to manage it, so their patient education, but also get some clinical data back into their primary care or specialty care network. So making sure they're able to get to their appointments, get their meds, those kind of things. So that case manager really follows all of the people of that condition, but also helps them with transition of care.
Great. Thanks so much, Phyllis, for expanding on that a little bit more. Another audience member is curious about the ACO model in general. They're wondering, is the ACO the only model to achieve goals in these situations?
I'll answer that. I don't think so. So bundles, even if you're not in an ACO and you have a CJR bundle, or if you have another bundle, that is an area where you can achieve savings. I also want to say for hospitals who don't have bundles or an ACO, this can really impact your penalty on around readmissions. We found that even when we made a difference in our SNF readmissions, our overall penalty for readmissions as a whole from CMS went away. So there is upside from the penalty perspective as well.
Thanks for sharing that perspective there. Another question coming through is about national guidelines. An audience member is curious, is there a directory to find the national guidelines for clinical standards that you were talking about?
So it's really, again, disease-based. So for CHF, acute MI, that's really American Heart Association. I know they publish guidelines. So it's really a national association. There's a Geriatric Fracture Society for fractures. It's really disease state or specialty physician driven. Whatever they say those standards are for that particular disease process.
Excellent. Another audience member is curious, what are your thoughts on service level agreements?
So in our network, we did not use them. However, I have seen them used effectively in other ACOs and other networks. I think it depends on where you're at in the country, what your expectations are, and how you can drive engagement. So I have seen them be very useful.
Absolutely, just some variance on who they may be best for. Next question that someone is curious about, this process that we're talking about, does it also work to set it up between the primary care provider in an ambulatory setting with the PACN?
So it does, and I would say as you start to build your network, if you own primary care practices, you need to include them in this. It depends on a couple of things. Who is providing care in your post-acute network? Do you have physicians who are providing care at the SNF? Obviously, when a patient goes home with home care, the primary care physician is managing that. So we did bring in our primary care practices. That's part of our CIN, our clinically integrated network. And I think that was very valuable because then all of our primary care physicians were managing the disease process in the same way.
That's really interesting. Thank you for expanding on that. Another audience member is curious about ACOs again, and is there initial buy-in to create an ACO?
I'm guessing they mean from a financial perspective. So that I would refer you to CMS as to what it takes to set up an ACO. You have to have a network of physicians and providers. You do have to be capitalized financially in some way or have those reserves. But I wouldn't say I'm the expert on that. Shane, I don't know if you have anything that you want to answer for that.
You know, I think you explained it very well, and yes, we don't know necessarily the exact costs that go into it. There is certainly expense up front to do it, but yeah, we would refer to someone else for the expert there.
Excellent. CMS is the expert there. Heading into the next question, how are case managers tracked within the system? And this can mean their PAC recommendations in and out of the network, or are they tracked by medical condition, payer type? A little bit more information about how those case managers are tracked would be appreciated.
Sure. So I think it depends on how your case management platform is structured. So we had case managers on the inpatient side, we had case managers in the post-acute, and then we also had ambulatory care case managers. So they needed to be able to hand off from one care setting to the other. If a patient went from a hospital to a SNF, the acute care case manager would hand off to the post-acute care manager, and then when the patient was transitioned back to their primary care or ambulatory practice, we transitioned those patients back to the ambulatory care manager. I think as far as what they did, we looked at facilities and how they had impact on length of stay. We looked at those high-risk cases and the percentage of those that they were able to prevent readmissions. We looked at what types of interventions they did. So it's not that we rated or ranked them, so to speak, but they led some of the development of the clinical pathways and the deployment of those type of clinical standards across the network.
Absolutely. So those interventions like length of stay and preventing high risk, those are things that you were looking at. The next question coming through is, how did you develop and implement standard clinical pathways? And as a follow-up to that, how important is it to have all aligned medical directors?
So what we did by disease process, so the first one we did was fractured hips. We worked with our orthopedic division to talk about what that would look like from a post-acute care perspective, what they would want to see, what are their standards of care. We developed that. It went through our orthopedic division. Then the next thing it did is it went to our medical directors of our preferred provider network. Many of those were owned physicians. They were geriatricians who worked in those SNFs, but some of them were not owned, but we would bring them to the table, review all those pieces, and then they would approve that, which led to approval at each individual facility. I think having those medical directors aligned is very important. They are the people who can drive change, particularly process change, in the facility, and facilities respond very well to their medical directors. So that's a really great point that I didn't talk about earlier, so I'm glad that question was brought up.
Yeah, definitely. Thanks so much for your perspective there. It's really appreciated. We have so many questions coming in, so really want to thank the audience for their participation. And another one is around technology platforms, and they're curious, do you use a technology platform to communicate with SNFs, to get patient records to the SNF, or is that handled by phone or fax still?
So when we were choicing, and I use the word choicing, I don't know if that's appropriate, a patient who was going from an acute care facility to our SNF, we did use a technology program. There's several of them out there. In that program, we were able to electronically send a defined packet of information that included, last set of nurses' notes, therapy notes, medication sheets, most recent physician orders. There were about 10 or 15 things so that the patient, or so that the facility could look at the patient, make sure they were able to care for them, and then they had that information electronically. So I think that is very important. One of the things I would say, though, as we were transitioning patients out, we would fax a one-page sheet that had updates on it about 2 to 3 hours prior to the patient leaving the facility, and then we would call a verbal report that also went over the things on the sheet so that the skilled nursing facility had an opportunity to ask questions. So most of the communication was electronic. However, we did fax and we did phone. We felt that a warm handoff really improved and cut down on transition of care errors.
Got it. Thank you for the insight there about the mix that those two are used in these situations. Another audience member is curious, have you used any software platforms which have been helpful to overall cost reduction and positive outcomes?
So I think you could take that a couple of different ways. So the platform that we used was real-time. That gave us the information from a clinical perspective directly into that facility EHR. So we were able to see what was happening with the patient and could intervene. As far as platforms for data evaluation, the ACO had a platform that they used to evaluate based on claims data. And so that was helpful from an overall look-back perspective. But, excuse the pun, in real time, we used the real-time medical systems platform to improve care and act upon those interventional moments.
Great, thank you for that answer there. This next question is about some metrics, and an audience member is curious, did you see any metrics similar to decreasing length of stay in acute care with the changes in post-acute care management?
Actually, we did, and that's a really great question. So our ACO did not have a waiver, so we could not waive the 3-day length of stay, but we were very close to doing that, particularly on fractured hips. Once our length of stay for fractured hips in the acute care side used to be about 4 to 4.2. We got that down to about 3.5 because we knew The SNFs were ready to care for the patient. They had the clinical plan, and we did choicing, right up front once we knew the patient needed a post-acute stay. We worked with their family and told them, hey, we have a program with these facilities, and your length of stay in the facility is going to be under 14 days. It was typically around 12 days for a fracture, barring any complications. So we were able to move people out quicker because we knew the standards that were being deployed at the post-acute facility.
Yeah, 3.5 is really impressive. Thank you so much for sharing that insight there. Another audience member is curious, what would be a preferred way to ensure the preferred providers are following the designated care pathways for certain diseases?
So we had triggers, if you will, in the real-time platform so that if a patient was not progressing, either from a functional or clinical perspective, that would trigger an alert, and our case managers would talk to the facility about what was happening with the patient. There were two other pieces we used. We used an onboarding program at the facility that our case managers participated in by phone, setting goals up front with the patient and identifying an estimated discharge date right up front. And then we would get progress reports on where that patient was. So if the patient was to be discharged in 12 days, at day 5, we understood where they were, if there were any setbacks, barriers, or anything we needed to change. So that was something we kept on top of. We also tracked all patients who went on our any one of our clinical pathways, from a readmission rate, length of stay, and then we had some specific outcomes from a functional status as well. So if there was a fractured hip, were they able to hit their 150 feet walking? When did they get to that? Those kind of things. So there were some specific metrics we used in each one of those disease types that we would measure, and that would show us how people were utilizing the clinical pathways.
Yeah, excellent. Thanks so much for giving us a little bit more of a window into how those metrics are used. This next question is about direct line of sight. An audience member is curious, who's responsible for direct line of sight? Is it social workers, physicians, or a different person?
So on our side, we had nurse case managers who looked at those clinical things every day. They would log in, take a look at all their patients, look at seeing who was high risk, if there were any clinical alerts that they needed to address or keywords in their chart that were concerning. And then they would contact the facility to see what was happening with that patient, if there was anything that the facility had done to mitigate that risk. And then if it was they needed to talk to a cardiologist and cardiology wasn't getting back to them, they served as that glue or that conduit back to specialty care. So our case managers would get a better response from a specialist than typically you would see getting a response from a SNF calling. So they kind of served as that glue to make sure that the right people had the right information to impact the patient's stay.
So nurse case managers are the people in those situations with the direct line of sight. Thanks for expanding on that. We have time for one more question today. I just want to thank the audience again for all of their participation. It's been a really excellent discussion. And so this question is about the CHF example. So going back to that example, if primary care providers can be considered into the post-acute care network with the daily wait requirement, how do you see patients who are discharged from the hospital? Can you monitor their daily weight using primary care services and not SNLS?
So yeah, once they went back to the community, we had a program. So we had two ways to approach this. We had a CHF clinic who would monitor those things. So if the patient was deemed a high risk or a critical patient, they would get a Bluetooth enabled scale, and that information will go back directly to our CHF clinic, and they know those patients well. If they were not a high-risk patient, we would ask the patient to do their weights and send them in via the electronic medical record. We also had what we called rescue diuretic plans. So the patient was instructed when they went home, if they gained, 3 to 5 pounds in 24 to 48 hours, they could give an extra dose of X, whatever that diuretic was, but they had to call the CHF clinic. So we kept a really tight line of sight on that and really gave patients the ability to help manage their own disease process.
Great, thanks so much for that. And before we end today, I just want to make sure, Phyllis or Shane, is there anything additional that you want to hit on before we sign off?
Thank you very much, everyone, for joining us. We appreciate your time and attention. It was important for you to be here. Excuse me. Thank you.
Yeah, I think I've certainly talked enough, so I appreciate everybody's time and the questions and engagement around this.
Well, it's just great. So that is all the time that we have time for. Today, I want to thank Shane and Phyllis for their excellent presentation and Real Time Medical for sponsoring today's webinar. So please enjoy the rest of your day, and we look forward to having you join us for future webinars.